The title of this talk is Headaches and Migraines. I'd like to start this talk with a question. What hurts? Brain parenchyma is for the most part pain insensitive. So what hurts when you get a headache? In the head, pain-sensitive structures are present intracranially and extracranially. Intracranial pain-sensitive structures are the dura at the base of the brain, venous sinuses, especially those at the base of the brain, the middle meningeal artery, the anterior cerebral artery close to the base, the intracranial segment of the internal carotid artery, and the middle cerebral artery close to its origin from the internal carotid artery. Some nerves are also pain-sensitive structures. The trigeminal, glossopharyngeal, vagus nerve, and the C2 and C3 sensory nerves are considered pain-sensitive structures. Some authors consider the optic and the oculomotor nerves pain-sensitive structures. A few authors include the periaqueductal gray matter, indicated here, and the thalamus as pain-sensitive structures. Extracranial pain-sensitive structures are the skin, subcutaneous tissue, periosteum, and the bones. Sinuses are also pain-sensitive, including frontal, ethmoidal, sphenoidal, and maxillary sinuses. So are muscles, frontalis, temporalis, occipitalis, trapezius, sternocleidomastoid, and masseters. The cranial aponeurosis is also pain sensitive, as are the large extracranial vessels, especially the superficial temporal artery. How is pain produced in these structures? The basic mechanism of head pains are irritation and traction of the nerve within the above mentioned pain-sensitive structures. Headaches, from the patient point of view, are good or bad. Good when not intense, bad when intense. For doctors, good and bad headaches have a different meaning. A good headache is one produced by a condition that a delayed diagnosis has no medical deleterious consequence. In this group of headaches, we have tension headaches. A bad headache is one produced by a condition that, if not promptly diagnosed and treated, leads to brain damage. In this group of headaches, we have those produced by sinusitis, meningitis, encephalitis, temporal arteritis, aneurysms, venous malformations, and brain tumors. So, what are the red flags that let us know we are dealing with a bad headache? The symptoms that should make you think your patient has a bad headache are presented in this list. Stop the video and read them, learn them. Signs that should make us think of bad headaches are presented in this frame. Again, stop the video and read them, learn them. I will detail two of them in the next few frames. The first one is local tenderness. Local tenderness is detected by skull palpation. One important condition that courses with local tenderness is giant cell temporal arteritis. I will spend a few minutes telling you about it. In this frame, you can see the common carotid artery and the external carotid artery. Arising from the external carotid artery, you can see the temporal artery. This segment of the artery indicated appears especially vulnerable to giant cell infiltration. Giant cell infiltration of the segment, as viewed in this histological specimen, leads to prominence of the artery. The cause is unknown. Giant cell arteritis is more common after 60 years of age. The clinical findings in giant temporal arteritis are headaches, and the most feared one is blindness. Blindness is usually caused by arteritic anterior ischemic optic neuropathy. I have reintroduced the figure of the head circulation to show you the irrigation of the optic nerve and point out the location of the pathology in this condition. Here we have the internal carotid artery and the ophthalmic artery. Patients with giant arteritis also suffer from jaw claudication. Jaw claudication is due to insufficient blood flow to the masseters during mastication. As you can see in this frame, I have indicated the external carotid artery and the maxillary artery. Limited arterial flow in the maxillary artery causes jaw claudication. In addition to jaw claudication, local tenderness, as we initially mentioned, over the protruding artery is often present. This area is exquisitely sensitive to touch. Regarding laboratory investigations, I like to mention set rate. In these patients, blood collected in a test tube taped upright at the headboard of the patient's bed for 1 hour will reveal significant red blood cell sedimentation. This indicates an elevated sedimentation rate. About treatment, one word: steroids. The second red flag sign I want to highlight is head tilt. I will do so by presenting to you a case published in the Korea Journal of Clinical Neurology. Notice that on the left side, this young man has a head incline of 12 degrees, whereas on the right side, the incline is 23 degrees. This represents a right head tilt. I will now reduce this photograph, as you can see, and introduce a close-up picture of the patient with his head tilted to the right, his preferred position. In this position, no double vision is present. Now I have introduced a close-up photograph of the patient with the head tilted to the left. Upon taking this position, double vision appears and there is a large separation between objects because left eye intorsion fails. This maneuver, when performed by the patient looking through a pair of glasses with different color lenses, allows us to identify the image from each eye individually. This maneuver, the tilting of the head while noticing the separation of images, is called the Biel-Schowski head tilt test. The findings just described indicate it is likely that the patient has an isolated left trochlear nerve palsy. I have now reintroduced the previous image here. I have done so to make room in the frame to show the clinical characteristic of double vision produced by isolated left trochlear nerve palsy. When looking up, no double vision is present because the superior oblique needs to be relaxed for this movement and it is already weak. When looking at the mid-horizon, the separation becomes greater as the gaze goes to the right side. You can tell just by looking at the pictures that the left eye is higher than the right eye. This is due to the unopposed action of the inferior oblique due to weakness of the superior oblique in the left eye. When looking down, double vision is even worse when gazing right for the same reason. This is a sagittal MRI from this patient. It showed a pineal tumor that you can also see in this transverse cut. The radiologist's conclusion was a well-circumscribed pineal tumor compressing the tectum. The tumor was a pilocystic astrocytoma. This is a view of the brainstem, which includes the pineal gland. If we go to the quadrigeminal plate and at the mid-upper region of the inferior colliculus make a transverse cut aiming up, we will see, after using a myelin stain, a specimen like this one. I have now placed a square in the area of interest and enlarged the chosen region. I have done so in order to better see the right trochlear nucleus, which once identified in the larger figure can easily be recognized in the original figure. I have now placed an arrow indicating the left trochlear nerve. The left trochlear nerve arises from the right trochlear nucleus. Why is this important? You can see in this frame the right trochlear nucleus from which the left trochlear nerve arises. A lesion in the right trochlear nucleus produces left superior oblique weakness. A right interparenchymal lesion hitting the fibers destined to become the left trochlear nerve will also produce left superior oblique weakness. A left trochlear nerve lesion will have the same effect. Two more things about head tilt before leaving the subject. One relates to the primary position of the right eye, that is, of the eye with trochlear nerve involvement. Notice where the arrows cross in the right eye. The site of the crossing indicate the vision axis. Notice that it is up and extorted. This drives the head to tilt to the opposite side and to tuck the chin in order to look up and avoid the use of the superior oblique muscle. This posture produces the trochlear tuck. The second and last thing I will tell you about head tilt is that head tilt is not always due to eye problems. This is a representation of a head tilt in a patient with a weak right superior oblique. The head is tilted to the left. This is a representation of another cause of head tilt. The chin, in this case, is slightly lifted. This type of head tilt occurs with weakness of the sternocleidomastoid muscle, in this case the right muscle. Weakness of the right sternocleidomastoid muscle can occur because of right accessory nerve damage anywhere in its course. But in a patient with headaches, the possibility of a posterior fossa tumor compressing the accessory nerve at the foramen magnum must be considered highly likely. So I have brought back the red flag to make sure that you remember to look for the red flags in all patients with headaches. Finding one demands immediate care with utmost consideration for devastating conditions. Now, let's look at headaches from the perspective of their presentation. Headaches either present acutely, reaching maximal pain intensity in less than an hour, as indicated in this frame, or headaches can present insidiously. In this situation, it is usually a worsening, real or perceived, of a previously tolerated headache that drives the patient to see the doctor. I will first address acute onset headaches. This is a list of acute onset headaches. Stop the video and read it. I will address some of these conditions individually in the next few frames. The first condition I will address is suprarachnoid hemorrhage. There are certain points you should know about suprarachnoid hemorrhage. The headaches reach maximal intensity instantaneously or at most over a few minutes. The patient often describes headaches as the worst they ever had, some using the term thunderclap headaches, a term some neurologists reserve for similar clinical manifestations not associated with suprarachnoid bleed. The headache may be associated with neck stiffness, reduced level of consciousness, focal deficit, vomiting, or photophobia, but they may be absent, especially in the early hours following the ictus. CT or similar brain image studies should always be done prior to performing a spinal tap in patients with suspected suprarachnoid hemorrhage. Xanthochromia by visual inspection alone has a 50-50 chance to be present in patients with suprarachnoid bleed detected by other methods. Xanthochromia by spectroscopy is found in about 100% of patients with suprarachnoid hemorrhage when tapped between 12 and 2 weeks after the ictus. Now, I like to consider causes of suprarachnoid hemorrhage. By far, the most common cause is cerebral berry aneurysm followed by arteriovenous malformation and trauma. The most common location for aneurysms in the general population is around the circles of Willis, specifically at the junction of the anterior communicating artery and the anterior cerebral artery. This is so in the general population. In the pediatric population, a study published by the International Society of Pediatric Neurosurgery concluded that most aneurysms in children occur outside the circles of Willis. Risk factors for aneurysm and subsequent suprarachnoid bleed are, as I hope you can guess by looking at this frame, autosomal dominant polycystic kidney disease, and also, as I hope you can conclude by looking at this frame, Ehlers-Danlos syndrome. Other risk factors include smoking, high blood pressure, non-white people, and old age. So we cover suprarachnoid hemorrhage from this list, and we will now talk about cerebral venous sinus thrombosis. Risk factors for cerebral venous sinus thrombosis are hypercoagulable states, ear and sinus infections, infections involving the paracranial sinuses, frontal, ethmoidal, sphenoidal, and maxillary can lead to cerebral venous sinus thrombosis. So can dental infections. The clinical manifestations of venous sinus thrombosis depend on which sinus is involved. Clinical presentation of cavernous sinus involvement differ from the clinical presentation of sagittal sinus involvement, and both differ from the clinical presentation of posterior fossa sinus involvement. We will first talk about cavernous sinus thrombosis. The cavernous sinus is located at the skull base. Thrombosis of the cavernous sinus can produce significant eyelid swelling, sclera hyperemia, but what usually dominates the clinical presentations of cavernous sinus thrombosis is eye movement abnormalities, which I will explain in the next few minutes. This is a representation of the right eye. The arrow indicates the pull of the lateral rectus, which abducts the eye. Now, the direction of the pull of the median rectus, which adducts the eye. The just introduced arrow indicates upward deviation of the eye produced by the superior rectus contraction when the eye is abducted. The new arrow indicates the result of contraction of the inferior rectus when the eye is abducted. The new arrow indicates the action of the inferior oblique, which is up deviation when the eye is adducted. I have now introduced an arrow to illustrate the direction of pull of the superior oblique, which is down. This action is maximal when the initial position of the eye is adducted. In addition to lateral and horizontal movements, the eye has torsion or cyclotorsion movements. Extorsion means rotation in a way that the upper pole of the eye deviates laterally. Extorsion is conducted by the inferior oblique and the inferior rectus. Intorsion means rotation of the eye where the upper pole of the eye is displaced medially towards the nose. Intorsion or cyclotorsion is achieved by contraction of the superior oblique and superior rectus. It is also important to understand eye problems related to cavernous sinus thrombosis to consider the status of the levator palpebrae and the status of the muscle of Mueller in the upper eyelid, and in the lower eyelid, the status of the muscle of Mueller, as well as the function of the pupillary sphincter and pupillary dilator. Now, I want to shift your attention to the cavernous sinus. The arrow is pointing to the third cranial nerve. This nerve innervates the superior rectus, the inferior oblique, medial rectus, and inferior rectus. Injury to this nerve will produce down and out displacement of the globe, because only the lateral rectus and the superior oblique are spared. The pupil, deprived of parasympathetic input, will dilate, now being completely under the influence of sympathetic innervation. Ptosis will occur because the levator palpebrae will also be weak. If, in addition, the cavernous sinus thrombosis involves the fourth cranial nerve, as indicated here by the cross, weakness of the superior oblique will occur. Hence, the eye will go up to the mid-horizon, now free of the inferior pull of the superior oblique muscle. If the sixth nerve is involved, the lateral rectus will cease to function and the eye will take mid position. Involvement of the carotid sympathetic plexus surrounding the carotid artery will deprive the pupil of sympathetic input and the pupil will become mid-size. The lower eyelid will elevate and the upper eyelid will drop further because of Mueller muscle weakness. In addition to ocular abnormalities, cavernous sinus thrombosis involves V1, that is the ophthalmic branch of the trigeminal nerve, leading to pain in the scalp, forehead, and eye, and involvement of V2, the maxillary branch of the trigeminal nerve, producing similar symptoms in the cheek and nose. It is important to stress that the left cavernous sinus communicates with the right cavernous sinus. Those symptoms of cavernous sinus thrombosis tend to be bilateral. Having talked about cavernous sinus thrombosis, we are going to shift our attention to the sagittal sinus, that is to sagittal sinus thrombosis. The sagittal sinus, as its name indicates, occupies the sagittal position of the skull. The most distinctive finding in patients with sagittal sinus thrombosis is bilateral leg weakness. Bilateral leg weakness results from involvement of the right and left mesial primary motor cortex. In this figure, I have included a transfer cut of the cerebrum going through the motor cortex, and in addition, I have represented the homunculus. Notice the regional distribution of the leg muscles in the mesial surface of the hemispheres, and it is right there in the blue shaded area in this frame that the mesial thrombosis most often occur. Image-wise, sagittal sinus thrombosis should be considered in the presence of a CT or an MRI showing increased intracranial pressure, such as obliteration of the cistern around the brain stem without ventricular enlargement. Another sign of sagittal sinus thrombosis is the presence of delta sign. The reason for it to be called delta sign is obvious. After talking about sagittal sinus thrombosis, we will talk about thrombosis of the posterior fossa sinuses. The posterior fossa sinuses include the straight sinus, transverse sinus, occipital sinus, confluence of the sinuses, sigmoid sinus, superior petrosal sinus, inferior petrosal sinus, and the basilar venous plexus. The clinical manifestations of posterior fossa sinus thrombosis are often dominated by cranial nerve deficit, especially involving the 5th, 6th, 9, 10, and 11 cranial nerves. After cerebral venous thrombosis, I would like to talk to you about pituitary apoplexy. The pituitary gland sits in the pituitary fossa on top of the sphenoid sinus. Pituitary adenoma usually present to the neurologist because of excessive growth, bleeding, or infarction of the tumor. Growth of a pituitary adenoma compresses the normal pituitary tissue and chiasm, as well as compressing and stretching the cavernous sinus, producing ocular movement, visual, and endocrine problems. Large pituitary adenoma often bleed, producing pituitary apoplexy. This syndrome consists of acute eye finding characterized by extraocular and intraocular abnormalities similar to those we described regarding cavernous sinus thrombosis, and bitemporal hemianopsia. In addition to visual symptoms, pituitary apoplexy is associated with signs of hypopituitarism. The third reason pituitary adenoma present to a neurologist is infarction. Infarction as hemorrhage produce pituitary apoplexy. After pituitary apoplexy, I will say a few words about trigeminal neuralgia. Trigeminal neuralgia has been recognized for many years. This is a photograph probably taken by Harvey Cushing of a patient going through an acute episode. Trigeminal neuralgia can present in two ways. One called classical trigeminal neuralgia has a diagnostic criteria. Stop the video and read them. In the next frames, I will emphasize most salient features of this condition. The pain in classical trigeminal neuralgia is usually in the distribution of V1 or V2. The distribution of the pain for each patient is usually the same from the first to the last episode. The pain is sharp, lasting for a few seconds to 2 minutes, After 2 minutes, it is gone. Classical trigeminal neuralgia is caused by an abnormal vessel compressing the trigeminal nerve. Usually, vessels do not pinch upon the trigeminal nerve as you can see here. In classical trigeminal neuralgia, they do so to a different degree, from minimal to frank compression. Most of the time, the artery involved is the superior cerebellar artery, either main trunk or one of its branches. In addition to the superior cerebellar artery, other vessels that may compress the trigeminal nerve are the anterior inferior cerebellar artery, the trigeminal vein, and the petrosal vein. The second type of trigeminal neuralgia is referred to as symptomatic trigeminal neuralgia. The criteria for it is presented in this frame. Stop the video to read them. In the next frame, I will highlight the difference between classical and symptomatic trigeminal neuralgia. In classical trigeminal neuralgia, there is no pain between episodes. Once the 2 minutes pass, the patient feels relieved. And either there is no explanation for it or a vessel compressing the trigeminal nerve is present. In symptomatic trigeminal neuralgia, the pain may persist between episodes, and more importantly, a lesion other than the trigeminal nerve compression by a vessel is present. The treatment for trigeminal neuralgia is carbamazepine or oxocarbamazepine. Surgery is also possible to distance the vessel from the trigeminal nerve in classic trigeminal neuralgia or remove the cause in cases of symptomatic trigeminal neuralgia. Having talked about trigeminal neuralgia, I will briefly mention reader's headache. Reader's headaches are also called painful postganglionic Horner syndrome or reader's paratrigeminal syndrome. This syndrome consists of constant severe headaches in the distribution of V1 with a postganglionic Horner syndrome. Imaging studies may show internal carotid artery abnormalities including dissection, or at times the studies are normal. This ends our discussion of acute onset headaches. We will now address worsening headache. Insidious worsening headaches refer to headaches that are initially considered tolerable and benign by the patient, but as time goes by, the headache becomes intolerable or worrisome enough to drive the patient to see a doctor for it. Such headaches can be primary or secondary. This is a partial list of primary headaches. Stop the video and take a few seconds to read it. I will address each of them separately. Tension headaches are the most common type of headaches that drives a patient to see a doctor. Depending on the study, from about 80% to over 50% of patients going to the doctor for headaches do so because of tension headaches. Tension headaches have a diagnostic criteria. Stop the video and read them. In the next frames, I will emphasize most salient features. Tension headaches are non-pulsating and bilateral, often frontal in a band-like distribution, or in other occasions, they involve the temporal, zygomatic, and occipital regions bilaterally. At times, they extend to the back of the neck. They occur in the distribution of head and face muscles. For example, frontal headaches arise mainly from the frontalis. Tension headaches are not aggravated by exercise. Light and noise do not make headaches worse. After tension headaches, we will talk about migraine. Migraine headaches have a diagnostic criteria. Stop the video and read them. In the next frame, I will emphasize most salient features of this condition. Migraine headaches are unilateral, but not just limited to the periorbital region. They are not always on the same side. Migraine always on the same side are worrisome. Light and noise makes them worse. Migraine headaches are described as pounding or throbbing. They are aggravated by routine physical activity. The headaches are often associated to nausea and vomiting. Females are more often affected than males. Migraine is often triggered or exacerbated by certain food and drinks. Stop the video and learn the food groups in this frame. Red wine is by far the most common offender. Migraine may have a prodromal phase that starts up to 24 hours before the headaches and is characterized by irritability, depression or elation, drowsiness and yawning, or craving for specific foods. As you can see, migraine can be classified as common. Common migraine is the most common cause of migraine and is not associated with aura. Aura has a strict defining criteria. Stop the video and learn them. In general, despite the statement in quotation in the previous frame, think of an aura as a horse pulling a wagon, the wagon being the headache. In addition to common migraine, migraine can be classified as classic migraine. Classic migraine is defined by the presence of aura involving the primary, unimodal, or multimodal sensory cortical areas. The aura of classic migraine usually goes on for 5 to 10 minutes and gradually disappears in 20 to 30 minutes. They never last longer than 60 minutes. When the area involved is the primary visual cortex, the aura consists of hemi and optic hallucinations that take several forms such as fortification spectra, zigzag lines, incomplete jagged circles, or unformed flashes of light. These hemi and optic hallucinations, as shown in this frame, are, as previously mentioned, the consequence of involvement of the primary visual cortex corresponding to the area indicated in this frame. More rostral lesions involving the parieto-occipital unimodal or multimodal association areas, or those involving the occipital-temporal association areas, even when restricted to one hemisphere, can produce bilateral optic hallucinations and even body distortion hallucinations. Hemiplegic migraines are defined by the aura. The aura in this type of migraine reflects primary motor area involvement. There is a familiar variety of hemiplegic migraine, but not all affected members within the family of a patient with hemiplegic migraine suffer from hemiplegic auras. Vertebrovascular migraines refer to migraines headache preceded by signs of brainstem dysfunction, such as diplopia, vertigo, ataxia, and dysarthria. These findings correspond to involvement of the vertebrovascular circulation. Ophthalmoplegic migraine is the odd migraine. In all the migraines we have discussed so far, the aura precedes the headaches, not so in ophthalmoplegic migraine. And that is the reason for the last sentence in the aura criteria list being in quotation marks. In ophthalmoplegic migraine, the headaches precede the aura. The pain in this type of migraine is unilateral, periorbital, follow hours later, or sometimes coinciding with signs of unilateral third cranial nerve deficit, and less often by signs of unilateral fourth cranial nerve deficit, and rarely by unilateral sixth cranial nerve deficit signs. Ocular findings in ophthalmoplegic migraine usually last longer than the headache. They may last for days. A frequent finding in patients with ophthalmoplegic migraine is third nerve enhancement in the cisternal region, as you can see here. Hence, although Classified as migraine, this condition, now often called ophthalmoplegic migraine, is in reality a recurrent ophthalmoplegic cranial neuropathy of unknown etiology. Now that we have talked about the pathogenesis of ophthalmoplegic migraine, I'd like to talk to you about the pathogenesis of migraines in general. That is, of all migraines except ophthalmoplegic migraine. To talk about the pathogenesis of migraine, uncertain as it is, we must describe four anatomical systems. The first one is the trigeminal cervical complex. The trigeminal cervical complex involves different regions of the brain and the upper cervical spinal cord. I have now represented the meninges by the double line surrounding the brain. The posterior fossa meninges sensory innervation is to a great extent from the cervical roots, as we previously mentioned. The tentorium and the rest of the brain dura is innervated by the trigeminal sensory branches. I will now, for clarity's sake, represent all the meninges in this enlarged figure. I will now label each of the components in this enlarged figure. In this frame, I am pointing to the meninges, now to the vein, now to the artery. One of the two sensory nerves, this one from the trigeminal ganglion, proximal axons of this neuron enter the medulla and make contact with the spinal trigeminal nucleus closer to the caudal region than to the rostral region of the nucleus. Now I am pointing to the second sensory nerve, fibers. These fibers arise from the cervical dorsal ganglia root. The proximal axon of these neurons make contact with the contralateral sensory neuron in the spinal cord at the tail of the trigeminal spinal nucleus. This constitutes the trigeminal cervical complex. The second anatomical system we must consider in order to understand the alleged pathophysiology of migraine is called the trigeminal autonomic reflex. In this frame, you can see the trigeminal cervical complex we introduced just a few minutes ago. This complex is the trigeminal arm of the trigeminal autonomic reflex. I will now explain the autonomic arm of this reflex. This nerve is made of postganglionic parasympathetic fibers that arise from the pterygopalatine ganglia. The neurons in the pterygopalatine ganglia are innervated by preganglionic parasympathetic axons arising from the superior salivary nucleus, also called, at least part of it, the lacrimal nucleus. Now, I want you to turn your attention to the spinal trigeminal nucleus. Neurons in this nucleus connect with the superior salivary nucleus, thus forming a loop between sensory and autonomic neurons innervating the meninges. In this loop, sensory information from the meningeal vessels travel towards the central nervous system through the trigeminal cervical complex, landing in the spinal trigeminal nucleus. From the trigeminal spinal nucleus, the signal goes to the parasympathetic superior salivary nucleus. From the superior salivary nucleus, parasympathetic motor signal travels to the pterygopalatine ganglion, and from the pterygopalatine ganglion, motor command travels to the meningeal arteries and probably to the meningeal veins. The action of this reflex produces arterial vasodilatation and probably inflammatory changes in the meninges. The third anatomical system we must consider in order to understand the alleged pathophysiology of migraine is the trigeminal autonomic reflex modulating structures. The trigeminal autonomic reflex is controlled by the action of several centers that convey the regulatory action by acting upon the spinal trigeminal nucleus, especially the caudal portion of this nucleus. I will now name the most important modulating structures. I will start with the nucleus raphe magnum, locus coeruleus, The connections between the spinal trigeminal nucleus and the locus coeruleus are bidirectional. Next connection of the spinal nucleus of the trigeminal nerve is with the dorsal raphe nucleus, which is in the periaqueductal gray matter. This connection is also bidirectional. The next connection of the spinal nucleus is with the posterior hypothalamus. This connection is also bidirectional. The last connection of the spinal trigeminal nucleus I will mention is with the thalamus. This connection is unidirectional from the thalamus to the spinal nucleus. The fourth anatomical system we must consider in order to understand the alleged pathophysiology of migraine are the connections of the center just described with the cerebral cortex. The interaction between the modulating elements just described and the cerebral cortex is very extensive. Neurons in the locus coeruleus send axons to all confines of the cerebral hemispheres. Neurons from the posterior hypothalamus send axons and receive axons from many areas of the brain, particularly from the limbic system. The axons of neurons in the periaqueductal gray region are also widely distributed. Axons of neurons in the thalamus are connected with many areas of the cerebral cortex. So, what is the pathogenesis of migraine? First, let me say that what I am about to tell you is a hypothesis which I have simplified, hopefully not to the point of making it a lie. So I have brought back the model I have just explained to add a chronological account reflecting the currently believed pathogenesis of migraine. First, cortical sensory depression secretes substances that excite the trigeminal and cervical sensory nerve afferent fibers present in the meningeal vessels. Once a signal is generated, the signal travels proximally, ultimately reaching the trigeminal spinal nucleus. Failure of the regulatory influence of the previously described modulating elements alters the regulatory capacity of the spinal trigeminal nucleus. The consequence of the loss of regulatory capacity is overstimulation of the superior salivary nucleus. The overstimulation reaches the pteriopalatine ganglion and produces meningeal arterial vasodilatation and pain. It has been postulated that abnormal spinal trigeminal nucleus modulating elements in this circuit, either in the brainstem, hypothalamus, or thalamus, are the cause of secretion of noxious substances by the cortex and dysregulation of the spinal trigeminal nucleus. So, having finished talking about migraine, we will briefly talk about cluster headaches. Cluster headaches are diagnosed when certain criteria are met. In this frame, you can see the criteria for cluster headache. Stop the video and read them. In the next frames, I will emphasize most salient features of this criteria. Headaches are very localized to the periorbital region. The pain is described as pressing or tightening of the eyeball. The pain is not pulsating. The pain is very intense, described as suicidal-like. The headaches occur in clusters, which may last from 1.5 to 3 months. The interval between the clusters vary, but it's usually about 3 months. Yet, in each individual, the interval between clusters tend to be fixed. During the cluster, the patient has 1 to 8 episodes of headaches per day, lasting from 15 to 180 minutes. The onset of the headache is always at the same time. It is said that you can set your clock by it. They usually start at night, but at time they may be precipitated by drinking alcohol or performing exercise. As stated in the criteria, at least one ipsilateral autonomic finding must be present in association with the headaches. So ipsilateral to the headaches, we will find one or more than one of the following manifestations. due to parasympathetic hyperactivity, conjunctival hyperemia, and lacrimation, due to oculosympathetic paresis, ptosis of the upper and lower eyelid, and meiosis. In the nose, rhinorrhea and nasal congestion, and in the face, hemifacial sweating due to parasympathetic excitation. In addition, patients with cluster headaches tend to be agitated and restless, unlike those suffering from migraine that prefer to be quiet and still. Cluster headache usually starts between 25 and 45 years of age. Men are more often affected than women. The pathophysiology of clusters is also poorly understood, but it is clear that it must answer two questions. Why parasympathetic findings? To answer this question, I will use the migraine model, but to make room in our minds and in the frame for more details, I have removed the labels. I have now introduced the eye and the nose and their corresponding parasympathetic innervation from the pterygopalatine ganglia. As in migraine, during cluster headaches, the trigeminal autonomic reflex hyperfunctions, but in this case, the pterygopalatine eye and nose connections get involved. This is the cause for lacrimation and rhinorrhea, conjunctival hyperemia, and nasal mucosa congestion. Next, we must ask ourselves why sympathetic findings. To explain sympathetic findings, I have gone back to the tracing of the trigeminocervical complex and trigeminal autonomic reflex, but this time added an slanted view of the cavernous sinus. I have now pointed to the intracavernous sinus portion of the carotid artery. This artery is innervated by fibers from the pterygopalatine plexus, just as the meninges arteries, and therefore excessive stimulation produces carotid artery dilatation. I will now proceed to isolate, as I have done here, and enlarge by several magnitudes the cavernous sinus, as you can see, in order to bring you to this frame. I have done so we can better visualize the sympathetic plexus around the carotid artery. These fibers are the postganglionic fibers arising from the superior cervical ganglion. These fibers constitute the third neuron of the oculosympathetic pathway, and when stretched as a consequence of carotid artery dilatation, they produce ptosis and meiosis. As you can see in this photograph taken of a patient soon after left-sided cluster headaches attack started. Note the Horner syndrome ipsilateral to the headaches. In this photograph, you can also see increased facial sweating exclusively around the left eye resulting from parasympathetic overstimulation. MRI of some patients with cluster headache show unilateral hyperactivity in the thalamus, giving credence to the notion that thalamic dysfunction is involved in the production of cluster headaches. The first line of treatment of cluster headaches is oxygen. Medication can also be helpful. With the discussion of cluster headaches, we conclude our review of primary headaches. I will now move on to say a few words about secondary headaches. I will only mention three of the many conditions associated with secondary insidious worsening of headaches. The first one is analgesia misuse headaches. Analgesia misuse headaches are probably the most common cause of chronic daily headaches. Analgesia misuse headaches occur in patients taking many analgesics. The history we usually get is one that suggests initial improvement with each new analgesic followed by rebound worsening. The treatment is to stop analgesic, offer psychological support, and wait. It takes about 1 to 2 months of medication to see benefits. Brain tumors are not a frequent cause of headaches, but brain tumors are usually the number one concern of patients when they seek medical help. Brain tumors are also the main concern of doctors seeing patients with headaches. This frame shows the most important red flag findings that you may see in patients with headaches due to brain tumors. Stop the video and memorize them. The last condition I want to mention is pseudotumor cerebri, or idiopathic intracranial hypertension. This condition tends to occur in relatively young fat females and in patients taking an excessive amount of vitamin A or taking tetracycline or danazol. Danazol is an androgen similar to testosterone used for the treatment of endometriosis and fibrocystic breast disease. This frame shows the frequency of different manifestations found in patients with pseudotumor cerebri. Stop the video, read them. In the next frame, I will highlight the most notorious one. After headache, transient visual obscuration, usually lasting few seconds, are the most frequent manifestations of pseudotumor cerebri. Other manifestations are double vision, often due to cranial nerve 6 deficit, bilateral visual field defect characterized by an enlarging blind spot and a constricting peripheral field. This is due to papilledema. MRI should always be done in patients with suspected pseudotumor cerebri in order to exclude structural lesions such as tumor, obstructive hydrocephalus, and sinus thrombosis. Their presence excludes pseudotumor cerebri, but certain pathological findings may be found in MRIs of patients with pseudotumor cerebri. MRI findings in these patients are empty sella, cerebral venous sinus stenosis as indicated in this frame, protrusion of the optic nerve head as indicated here, and horizontal tortuosity of the optic nerve. In this frame, I have included two sets of values for adult opening pressure because they are both equally quoted in the literature. I have also included normal values for children and neonates. These values are given in centimeters of water and correspond to lumbar puncture preform with the patient in a flexed lateral decubitus position. In adults, values over 25 are considered abnormal and in the right setting diagnostic of pseudotumor cerebri. Treatment options are included in this frame. Stop the video, read them and learn them. Thank you very much for your attention.